Hi, my name is Tom Chen, and I am Professor of Neurosurgery and Pathology at USC. Today, I'm going to talk to you about a very exciting mode of delivery. It's called intranasal delivery, and we're using intranasal delivery for delivery and treatment of brain tumors. And I'm also going to talk to you about other clinical trials that we want to do along this route. So I want you to know that I am founder and CEO of a startup company that called Neurological Technologies, and I have shares in Neurological Technologies. What is intranasal delivery? Well, intranasal delivery is something I think that you're all familiar with, and basically is delivery along the cranial nerves. And the cranial nerves that we were talking about is the first and fifth cranial nerve. Now, what happens with the cranial nerve delivery is that what we're trying to do is bypass the blood-brain barrier. As you know, many drugs are resistant to getting across the blood-brain barrier because that's one of our forms of protection. With nasal brain delivery, what we're doing is that we're inhaling a drug and allowing it to go through the nerves of the nose to something called the olfactory nerves. Olfactory nerve is the first cranial nerve, and it goes from the olfactory nerve to the olfactory bulb, olfactory tract, then to the brain. And using this route, we basically are delivering drugs to the brain using the cranial nerves. The other cranial nerves that we have determined in the laboratory setting that's involved is the fifth cranial nerve. The fifth cranial nerve is the trigeminal nerve, and it supplies sensation to the face, and also allows delivery to the area of the brainstem. In this picture, what you can see is what I'm talking about. You see how a mist is delivered to the nose, and that mist is then carried to the olfactory nerves that come out, and then through the cribriform plate, through the olfactory bulb, olfactory tract, to the brain. Now, this is a picture of a patient undergoing intranasal therapy. You see how he's breathing this treatment through the nose, and then it goes through the nose to the brain itself. So as you can see, it's a very non-invasive treatment and a very non-invasive way of getting drugs to the brain. So what we did was that we have a drug. It's called NEO-100. NEO-100 is based on another drug called para-alcohol. Para-alcohol is a cell cycle inhibitor, and para-alcohol is also a RAS oncogene inhibitor. We have also developed the NEO-100 as something called ER stress inhibitor, in that it induces ER stress and causes apoptosis. And here I have a schematic of basically what we're doing for synthesis of this NEO-100 or purified para-alcohol. We have a trial that's ongoing right now. It's called an open label phase 1/2A dose escalation trial to determine the safety and efficacy of NEO-100 in recurrent grade 4 gliomas. Gliomas are basically cancers of the brain. They're the most common intrinsic neoplasm, and grade 4 is the highest grade. It's also called glioblastoma. And this trial is basically based on glioblastomas that have already recurred despite treatment with radiation chemotherapy. So what we did was that we obtained something called IND. IND is investigative new drug. And we obtained a fast track status and orphan drug status for our drug. Our enrollment criteria, basically you have to be a grade 4 glioma or GBM. You need to have failed standard therapy, which is a chemotherapy drug called Timidar, and radiation. You need to be Avastin naive, which is another drug that we use as second-line therapy. It's an anti-angiogenesis drug. You need to have a Karnofsky score greater than 60 and tumor less than 3 by 3 centimeters. And what we have done is that we are running this trial in several sites across the United States at USC, the Cleveland Clinic, University of Wisconsin, University of Washington, and we're currently enrolling patients. Now, I want to show you what we're doing with our phase 1 trial. The phase 1 trial has already been completed, And what you can see here is that we were asked by the FDA to do a dose increasing trial using 4 cohorts. Cohort 1 is the lowest dosage at 96 milligrams per dose. Patients get it 4 times a day. And so at the end of the day, they get 384 milligrams of our Neo 100. As we dose escalated up to cohort 4, you can see that these patients get up to 288 milligrams per dose 4 times a day, or 1,152 milligrams per day total. Now, we enrolled a total of 12 patients for this trial, and you can see how it goes from 3 patients per cohort. And you can see that it's from a gender standpoint, it was an equal division of male and females. Most of the patients were basically between 50 to 70 years old. The ethnic group was reflective of of Los Angeles, which included Caucasian, Asian, and Hispanic patients. We had MGMT status, determine whether they're methylated or unmethylated. The MGMT is basically a DNA repair enzyme. If the patients are methylated, they have a defect in the MGMT, and therefore they are more sensitive to temozolomide treatment. And we also had the metabolic marker, IDH1 status, determined as wild type or mutated, and then also their Karnofsky score, whether how they were performing, and then tumor location. And you can see from the tumor location standpoint, most of these patients are basically in the frontal, temporal, occipital lobes. Now, as a phase 1 study, we want to know what the adverse events are. And adverse events we looked at included general disorders, nervous system disorders related to the brain, skin, respiratory problems, or blood and lymphatic system disorders. And we graded according to the dose escalation, going from 384 to 1,152 milligrams per day. And then we determined whether are these side effects that are recorded possibly related or definitely related to treatment. Now, the score of 1 is basically the lowest grade that you can have, and it goes up to a score of 4 with the severity. And you can see what happens is that the treatment adverse events are most likely related to the nose, and rhinorrhea being one problem, and then skin irritation. But there was no definitive problem with myelotoxicity or headache or other severe central nervous system toxicity. So from a standpoint of dose escalation, this was a very small increase in terms of adverse events experienced by these patients. Now, what we did was then we graded these patients in terms of how they did. Okay, now in terms of the completed cycles, each cycle was 1 month. And so if patients completed, for instance, 2 cycles, that means that they've had 2 months of treatment, and they stopped the treatment because they had an increase in their disease by MRI scan. And so we basically took the patients as how many cycles did they complete, and the RANO basically is an MRI criteria for progression. And so a RANO score of PD means that they have progressive disease. A RANO score of SD means that they have stabilization of disease. And then we looked at how long they survived. And this was graded in terms of months. And you can see that patients sometimes had no response at all, and they had a survival time of actually only 2 months. And then there are some patients that have very good survival time, as long as 33 months after treatment. And we graded these patients on how they're doing currently, whether they are still alive or deceased, and whether they're still undergoing treatment. Now, what was very interesting about this study, even though this is just purely a toxicity study, we found that basically 3 patients were alive much longer than we suspected. 1 patient has actually been alive for almost close to 3 years now. And you may ask, how long do these patients with recurrent GBM normally survive for? And the answer is about 9 months. And so to have patients that are survival as long as 33 months, that's really a very big difference. Now, I should also add that in terms of survival, we also did analyses based on not only progression-free survival, but overall survival. And here is a curve of progression-free survival, and this was mapped out for 6 months. And you can see that in cohort 1, these patients did not do very well from the standpoint of progression-free survival, but as we increased the concentration, especially in cohort 3, these patients did very well in terms of progression-free survival. This is a picture of some of these MRI scans. This is in A is the picture MRI scan of the patient that has been alive for 33 months. You can see how she started October 2017 with this white area that basically shows that her recurrent tumor. And as she inhaled the Neo-100, you see how that white area has decreased in size. Another patient started in May of 2018, and you can see that white area showing her brain tumor. And as she inhaled it over a 1-year time period, you see how that white area or contrast enhancing area completely goes away. We looked at overall survival for these patients, and these are basically months since starting the Neo-100 therapy. And you can see that basically in the patients that have, all the patients that have been treated, how that there's an overall survival in 24 months of 37%. And this is something that we would not expect to have seen in just recurrent glioblastomas. If we map it out into patients that have been had tolerated treatment for more than 5 cycles or less than 5 cycles, you can see how the patients with more than 5 cycles, that dark line, has basically had a very long survival time. And then what was very interesting in terms of the markers, we looked at the genomic markers, including MGMT status and IDH1 mutations, and we found that the patients that were IDH1 mutant had a very long survival time compared to the patients that had IDH1 wild type. In fact, the IDH1 mutants are all 3 of the patients that have survived and still getting treatments. These were all IDH1 mutants. And when we compare our study with other phase 1 trials, you can see that basically our survival time at 6 months, 9 months, 12 months, and overall median survival were it was basically the best that was achieved compared to other phase 1 trials. So our conclusion for our trial is that Neo-100 is very well tolerated, no significant side effects. Patients tolerate this treatment regimen very well without, and it induces radiographic reduction in size and recurrent GBM in a dose-dependent manner. We had 3 long-term survivals greater than 2 years, all with IDH1 mutations. This allowed us then to look at and think about future enrollment. We'll focus on recurrent GBM patients with IDH1 mutations. So we have other plans for intranasal delivery. In low-grade gliomas, these patients almost all have IDH1 mutations, and we're planning to enroll these patients for trials as well. Skull-based meningiomas often have IDH1 mutations, as far as 50% of these patients, and we are planning to do a trial with this. And then we also want to use Neo-100 as a solvent for delivery of other drugs to the brain, and then administration of Neo-100 in newly diagnosed glioblastomas during the temozolomide arrest period of the Stoop protocol. So basically in our trial today that I have presented, we have very promising results for our phase 1 trial. I want to emphasize to you that this is a phase 1 trial, and therefore the patient numbers are small. However, we are going to expand this into a phase 2A. I think the most clinically important result that we obtained for this phase 1 is that 1, this trial is very safe, and then 2, that we have a biomarker that can potentially be used to identify patients that can respond to this trial. And these will be patients with IDH1 mutations. We feel that this mutation basically identifies a particular patient with a recurrent glioblastoma that may respond to long-term treatment. Thank you very much.